This recording will go over appendicitis. Appendicitis is an acute inflammation of the vermiform or worm-like appendix that occurs most often among young adults. It is the most common cause of right lower quadrant pain. The appendix usually extends off the proximal cecum of the colon, just below the ileocecal valve. Inflammation occurs when the lumen or opening of the appendix is obstructed or blocked, leading to infection as bacteria invade the wall of the appendix. When the lumen is blocked, the mucosa secretes fluid, increasing the internal pressure and restricting blood flow, which results in pain. If the process occurs slowly, an abscess may develop, but a rapid process may result in peritonitis. All complications of peritonitis are serious. Gangrene and sepsis can occur within 24 to 36 hours, are life-threatening, and are some of the most common indications for emergency surgery. Perforation may develop within 24 hours, but the risk rises rapidly after 48 hours. Perforation of the appendix also results in peritonitis with a temperature of greater than 101 degrees Fahrenheit and a rise in pulse rate. Appendicitis is relatively rare at extremes in age. However, perforation is more common in older adults, causing a higher mortality rate. The diagnosis of appendicitis is difficult to establish in older adults because symptoms of pain and tenderness may not be as pronounced in this age group. The difference results in treatment delay and an increased risk for perforation, peritonitis, and death. History taking and tracking the sequence of symptoms are important because nausea or vomiting before abdominal pain can indicate gastroenteritis, where abdominal pain followed by nausea and vomiting can indicate appendicitis. Ask about risk factors such as age, familial tendencies, and intra-abdominal tumors. Classically, patients with appendicitis have cramping pain in the epigastric or periumbilical area. Anorexia is a frequent symptom, with nausea and vomiting occurring in most cases. Perform a complete pain assessment. Initially, pain can be present anywhere in the abdominal or flank area. As the inflammation and infection progress, the pain becomes more severe and steady and shifts to the right lower quadrant between the anterior iliac crest and the umbilicus. This area is referred to as McBurney's point. Abdominal pain that increases with cough or movement and is relieved by bending the right hip or knee suggests perforation and peritonitis. An advanced practice nurse or other healthcare provider will assess for muscle rigidity and guarding on palpation of the abdomen. The patient may report pain after the release of pressure. This finding is referred to as rebound tenderness. Laboratory findings do not establish the diagnosis, but often there is a moderate elevation of white blood cell count to 10,000 to 18,000, with a shift to the left and increased number of immature white blood cells. A white blood cell elevation to greater than 20,000 may indicate a perforated appendix. An ultrasound study may show the presence of an enlarged appendix. If the symptoms are recurrent or prolonged, a CT scan can be used for diagnosis and may reveal the presence of a fecaloma or small stone of feces. All patients with suspected or confirmed appendicitis are hospitalized, and most have surgery to remove the inflamed appendix. Keep the patient with suspected or known appendicitis NPO to prepare for the possibility of surgery and to avoid making the inflammation worse. Before surgical intervention, be sure that the patient's pain is adequately managed. For the patient with suspected appendicitis, administer IV fluids as prescribed to maintain fluid and electrolyte balance and replace fluid volume. If tolerated, advise the patient to maintain a semi-Fowler's position so abdominal drainage can be contained in the lower abdomen. Once the diagnosis of appendicitis is confirmed and surgery is scheduled, administer opioid analgesics and antibiotics as prescribed. The patient with suspected or confirmed appendicitis should not receive laxatives or enemas, which can cause perforation of the appendix. Do not apply heat to the abdomen because this may increase circulation to the appendix and result in increased inflammation and perforation. Surgery is required as soon as possible. An appendectomy is the removal of the inflamed appendix by one of several surgical methods. Laparoscopic appendectomy is minimally invasive. If the diagnosis is not definitive, but the patient is at high risk for complications from suspected appendicitis, the surgeon may perform an exploratory laparotomy to rule out appendicitis. A laparotomy is an open surgical approach with a large abdominal incision for complicated or atypical appendicitis or peritonitis. Pre-op teaching is often limited because the patient is in pain or may be admitted quickly for emergency surgery. If complications such as peritonitis or abscesses are found during open traditional surgery, wound drains are inserted and NG tube may be placed to decompress the stomach and prevent abdominal distension. Administer IV antibiotics and opioid analgesics as prescribed. Help the patient out of bed on the evening of surgery to help prevent respiratory complications such as atelectasis. He or she may be hospitalized for as long as 3 to 5 days and return to normal activity in around 6 weeks.